So let's move on to look at some of the goals and the definitions. So there's a definition of risk, then there's a new definition, very high risk. What are these goals? Do you have any idea on that you want to give us, Chris, and how you can find these patients?
Well, in goals, I think the traditional goal has been managing the diabetes and the hemoglobin A1C.
The glucose, the sugar.
And glucose
Okay.
has been the goal, and getting someone well controlled. But I think the most recent guidelines from the ADA have really put front and center reducing cardiovascular risk as what turns out to be a parallel goal, because the two are interrelated, but there are many things to reduce cardiovascular risk that may not directly relate to glucose, and managing glucose one way wouldn't necessarily reduce cardiovascular risk. And so it makes it tricky to try and do two things at once, but one that we have to rethink what is the goal or goals in managing the risk.
What are these other conditions that you're talking about?
Well, thinking about the various risk factors, obviously we've known that we should get patients onto ACE and ARB in part for kidney prevention and statins for coronary prevention. Now thinking about heart failure risk and diabetes medications, but cardiac risk with the newer agents of SGLT2s and GLP-1. But all of that runs sort of in parallel with the glucose. So just Monday, had a patient whose hemoglobin A1C was 6.7.
Pretty good.
Which is in theory good on metformin, but he had an MI 3 weeks ago. So I said, well, I know some classes of drugs that you need, but there's limited data. Shouldn't we be using this? So he was billed as well controlled, and yet I'm thinking we need to modify the risk. And so it becomes a dual goal to try and remember that we want to do things that interrelate, but sometimes they're a little different.
So Melissa, you have to treat these patients. What kind of approaches do you have to not just be glucose-centric? You're not just looking at the sugar. What else do you do? So
you are looking at the overlying risk that they have as well, and trying to, in some ways, minimize the burden of additional prescriptions. We tend to look at it as more bang for your buck. I know that if we have a patient who has an A1C that's elevated or even mildly elevated, but they're at high risk for heart failure or they've had an event, if I'm choosing something to change in their treatment paradigm, I want something that has that added benefit of some cardiovascular protection. And I think that's where the basis for the ACC guidelines comes in, and some of the changes with the guidelines at ADA is that we now fortunately have a lot of tools in our toolbox, but we don't want to just throw those tools at our patients. We want to pick the tool that actually fits their need, whether that's an SGLT2 inhibitor because someone's at a high risk for heart failure, or whether it's a GLP-1 because of an ASCVD event that they've had.
We're going to go into the outcomes trials that show support for what you're saying, but let's stick with the goals for right now. Let's first go with blood pressure. Seth, you want to comment on that? And lipids, I know that's your baby.
Okay.
Talk on lipids.
Well, first blood pressure. We want to keep blood pressure under 130/80, but you're the expert in blood pressure, so I'd love to hear your commentary. I'll throw that back at you. The nuances of that.
Well, I actually embrace the 130/80. If you look at the ADA, they suggest starting therapy at 140/90. And they give 130/80 as an option. The ACC AHA 2017 high blood pressure guideline categorically says 130/80, and I'll tell you why. If you do the risk calculator, you plug in a person who's middle-aged and older, and that person has diabetes, they almost always have a 10% or greater risk, so it places them in a higher category. People here say, well, ACCORD was negative. Well, ACCORD was a much smaller trial than some of the larger trials like SPRINT. Whereas the ACCORD was 4,700, SPRINT was 9,300. Larger patient population, higher risk, older patients, you'll see greater benefit. I don't think there's anything magic about having type 2 diabetes where you would not get the same benefit with the 130/80. And of course, it's physician's choice. Peter, what do you think about for the kidney? What do you do in terms of trying to protect persons with diabetes from chronic kidney disease progression?
Well, there 130/80 also fits, and in the SPRINT trial, where there was an attempt to go below a systolic blood pressure of 120, there was no additional renal benefit there. But as Chris points out, a fundamental for renal protection is use of renin-angiotensin system inhibitors. There's no doubt about it. ACE inhibitors and ARBs are the go-to drugs. The way I kind of integrate risk is the hemoglobin A1C best maps to retinopathy, neuropathy, and nephropathy.
Is that microvascular
It's
disease?
microvascular disease. That's the mapping function there. Sure, hemoglobin A1C participates in atherosclerotic cardiovascular risk, but as Chris points out, there's some really dominant things there, including elevations in LDL cholesterol, smoking, family history, uncontrolled high blood pressure. So the macrovascular disease, atherosclerotic cardiovascular disease, has a bigger mapping function than the end organ microvascular disease.
So you're looking at protecting not only the big vessels, but the small vessels in the eyes and the kidneys and neuropathy, which is the nerve
Right.
endings.
I mean, when I see a patient with a hemoglobin A1C of 10 or 12, my biggest concern is progressive retinopathy, nephropathy, neuropathy, and invariably patients are heading down that.
Chris, any input on that?
Well, you know, on the kidney disease, I nicely participated in the ADA committee the last few years, and I learned the importance of measuring albumin as another axis. So we get the EGFR, and everything's EGFR. We, you know, need that for dosing a lot of, but very infrequently have I thought about how much albumin is the kidney spilling. So the new risk table in the ADA guidelines has a 2x2 table of weaving in the stage with the albumin, urine albumin, as well as the EGFR. And I think in the even if the EGFR is a little bit down, if there's no albumin, that's a good thing for the kidney.
Yeah, I was going to say that we call that a heat map. And so it's a heat map looking at EGFR and the albumin to creatinine ratio. We're talking about just a single specimen, the ratio of albumin to creatinine in a spot urine. And the teaching point is when microalbuminuria is there greater than 300 or macroalbuminuria greater than 300, that we have a situation where the albuminuria is the single greatest driver of rapidly progressive kidney disease. That's what it indicates. Albuminuria is in general associated with heart failure and atherosclerotic disease, what have you, but there are relative risks that exceed 100 in those heat maps in patients who have a low GFR and they have significant albuminuria.
Isn't it also true that just, you know, and I've been using it this way, so I hope it's true, microalbuminuria as an excellent indicator of endothelial dysfunction. So you could say to your patient that, you know, this is your kidneys, you know, they may be in trouble, but it's also your heart and the rest of your body. Do you use it that way as well?
Yeah, we do. We published in Circulation an AHA statement about 15 years ago, and we had tables in that paper looking at every form of cardiovascular disease and what are the data for the albumin to creatinine ratio, and it was present across the board. And so there is a linkage there. The thought is exactly that. It is a reflection of a diseased endothelium.